Mm.
All right. Hello, everyone. Welcome to today's postgraduate course, New Solution for TB Management During and After the COVID-19 Pandemic, Updated WHO TB Recommendation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone has been muted to avoid background noise. You can request to speak via the chat. The chairs will let you know when you can intervene. We encourage you to turn your webcam on throughout the session. Can we please ask you to change your display name to your name and country? You can click on Participant on the bottom menu bar, hover the mouse over your name, click on More, click on Rename, enter your name and country on the screen name field, and click the OK button. You will have the opportunity to submit text questions and comments to today's presenters by typing your questions into the chat. You can send questions via the chat at any time during the session. The moderators will collect them and address them after the speakers' presentations in the allocated Q&A sections. You'll have the opportunity to intervene in today's session by submitting a request to do so via the chat or by raising your hand. The moderators will record your request and inform you when you can intervene. You will also have the opportunity to provide feedback in the end of the session's evaluation survey. You'll receive a certificate based on your attendance and the completion of the evaluation survey. It is now my pleasure to introduce you to today's chairs, Dr. Matteo Zignol and Professor Charles Darley.
Thank you very much, and good morning, good afternoon, good evening, everyone. I'm Matteo Zignol. I'm one of the co-chairs of this workshop with Professor Charles Daly, who will introduce himself in 1 minute. I work at the WHO as a medical officer, and I oversee the policy development work in tuberculosis of WHO. Again, welcome to everyone. This workshop is an historical workshop, I would say, at the Union. We have been organizing it for many years. It's usually quite well attended, and we look forward to the discussion. The main purpose is to share the latest WHO evidence-based recommendations in the various aspects of TB management, going from prevention, screening, diagnosis, treatment and care, and subpopulation, and have an opportunity to discuss and understand aspects related to adoption and implementation of WHO recommendations at national level. So we look forward to your feedback, to your questions, to your comments in the chat, and we'll have time after the presentations to hear your voice as well. With this, I hand over to Professor Chuck Daly, for continuing the introductions.
Thank you, Matteo, and welcome everyone to today's workshop. I'll have, first of all, I'm Chuck Daly. I'm Chief of the Division of Mycobacterial and Respiratory Infections at National Jewish here in Denver, Colorado, and excited to be part of today's workshop. I have the honor of introducing our first speaker today. The lecture is entitled WHO TB Knowledge, Sharing Platform and ETB Guidelines. I think everyone here knows quite well that the COVID-19 pandemic has accentuated the importance of rapid access to WHO guidance on essential health issues like tuberculosis. The presentation that we'll be hearing today will highlight some of the key features of the WHO TB knowledge sharing platform that was developed this past year to disseminate WHO information. The tool is available both for desktops as well as mobile devices. It allows the user to search, scroll, and customize content to their needs. So we'll be hearing from our first speaker, Dr. Dennis Falzone. Dennis works at the Global TB Program of the WHO in Geneva. Before joining WHO in 2008, he worked as a medical epidemiologist at the Euro TB Surveillance Project in France, and previously worked in public health as well as non-governmental sectors. He leads a team that works on TB prevention, research, and innovation. He's been involved in many aspects of TB disease and TB infection, the integration of digital technologies and efforts to support the NTB strategy, novel methods to disseminate guidance, and operational research on TB innovation. So he's the perfect person for us to hear today regarding knowledge sharing. So Dennis, if you could share your screen.
Thank you very much, Chuck, and thanks, Matteo, and greetings to everyone who joined this this program early or late. And I hope that with this first session, we will be able to go over some of the important developments in dissemination of guidelines that we prepared. I hope that you can see my screen. Okay, thanks very much. So first of all, I have no conflict of interest. I'm a full-time staff at WHO at Global TB Program, and I have been involved in the production of policy, but also the production of these products that I will discuss now. So among the challenges in dissemination of TB guidelines, and this is not limited necessarily to TB guidelines, but many other policy of WHO and international organizations, is the way of disseminating our recommendations and making our voice heard, particularly during this age of media. So we have to make sure that our products are out there and people know about them and understand them as well. So for a number of years, we have been sort of told that WHO TB recommendations, we're keenly aware recommendations are found in different documents. The style of the content differs very often. Sometimes outdated guidelines are still found on shelves and also online. The users may be interested in parts of guidelines, not others, right? And maybe particularly affected by certain recommendations which find themselves in different documents. Also that implementation aids and these how-to handbooks have not been always available, and also the WHO has not been involved in the creation of training material for a number of years or for certain aspects of TB, and was quite absent in terms of e-learning products in the TB world. Something which also I think pushed more the production and of the developments that I will mention is, of course, COVID has accentuated the importance that rapid access to latest guidelines is essential for particularly for diseases like TB, which risked being overwhelmed by the mitigation efforts to address the pandemic requirements. And as we have seen, the pandemic has moved the process from paper documents, which we usually sent over by mail or else disseminated during our physical meetings with countries and with our regional colleagues, into digital disseminated documents. And you can see that the COVID guidelines, for instance, have been disseminated through very novel means of spreading information through the social media. The process started actually, that I will mention, started just before COVID hit. We started by consolidating our guidelines under 5 modules, and these are listed here under prevention, screening, diagnosis, treatment, and then a group of comorbidities, vulnerable populations, and people-centered care. There is a color coding around these modules, which you will find in many of our products, and it serves to give some sort of common identity for the different parts of our guidelines. We started with the first guidelines that were released with their handbook under the first module of prevention, with the new TB preventive treatment guidelines that we released for World TB Day 2020 last year. And since then, we have populated we have added guidelines in the area of diagnostics, for instance, under module 3, and treatment under module 4, and more recently in World TB Day this year under module 2 under screening. By the end of this year, we will have at least 1 guideline and 1 handbook under each of the 5 modules. So by the end of this year, there will be childhood guidelines, which will go under the 5th module. So that is by way of background. Now we have prepared also in parallel with this process, what we call a knowledge sharing platform, which is essentially a microsite or a dedicated website with an app to go with it for mobile devices, especially smartphones. And this is intended to be a one-stop shop for people who use our guidelines and handbooks to access via their computers or their mobiles or their tablet computers the latest WHO TB recommendations and other resources that can improve implementation. So in one place, we have the consolidated guidelines, the implementation handbooks or operational handbooks, and a catalog of training material. So if you have your mobiles, you can access the KSP if you have not done this already through the iOS and Android shops, or else you can also access from the other side, the website itself. You can go to tvksp.org as a shortcut to find the website, and you should land on a page such as the one showing here. I want to highlight, there's a lot to say, of course, about how this website was produced and the features of it, but I'm highlighting in this slide 7 particular issues. One is about the place where you find the guidelines, handbooks, and eventually the training modules. Also, there is a quick search function. I will show it very quickly, and also access to the recommendation map, which I also wanted to speak briefly during this presentation, and then also possibility to customize your personal space. So I think one of the most important features that the KSP gives you, knowledge sharing platform gives you, is that apart from finding a PDF of the document that you want, you can also find the text as a web browser. So you can see it in these 2 formats. So the PDF version that is put in the KSP is actually in a special box or a PDF renderer, which allows some more flexibility. In particular, I think the nice feature of this is that you can actually choose pages that you want from different guidelines or even handbooks and stitch them together into your customized PDF. And then you can download that to your machine and use that as your guideline. Of course, you have to be aware that there are updates from time to time. So you may want to do this process every time there is a new guidelines coming up and put up your gain on your knowledge in one document. Of course, otherwise, some people might prefer to just bookmark things and have them available once they log in up here in the top right of the website. The training modules are coming up. This is like the 3rd box that you see in yellow here against my left shoulder. And this is a box that will be populated very soon in the coming months. We'll have 3 training modules on TB preventive treatment, on drug-resistant TB treatment, and on diagnostics coming up. So this will be, I think, an important addition, and which will complete a bit more the KSP as it stands right now. And these modules will have also certification at the end, so that people who complete them successfully can download a record of achievement. The quick search function, which is on the KSP, and you can access it from one of the tabs at the top of the page, is what it is. It's what it says. It is a way of searching across all the contents of the guidelines, handbooks, as well as the training modules eventually, for content which is of interest. You can do this either by a free search, keyword search, as you have in this dialog box over here, or else using these presets. For instance, if you're interested, let's say, only in people living with HIV or nutrition, and also you can limit it to certain modules, or also limit it by whether you want the handbooks or guidelines to be featured amongst the search. So this is, I think, for many of these websites, the key feature which makes or breaks their success is usually how efficient the search is. Through the knowledge sharing platform itself, you can also access this recommendation map or the ETB guidelines that has been produced with colleagues from McMaster University and Evidence Prime. And this gives you a different sort of function, which allows you to search by individual recommendations that you find in the different modules. You see over here again the subdivision of this recommendation map in these 5 modules. You have options to filter as well, or free search. And if you click on one individual recommendation that comes up from your search, you can open this details page, and the details page as well, you have links then which take you to the evidence. This is intended primarily for people who are interested to know how a recommendation came about, what is the evidence, what were the expert decisions and values that influenced its production, its wording, its strength, and the quality of the evidence that is behind it. And another function that is given by this ETB guidelines is actually the mapping function, for which it is named. And this is just presenting one of the cross-tabulations that is possible when you cross-tabulate populations or settings down the rows with the different intervention groups that you can classify the different recommendations in. And you see a sort of heat map which shows you where most of the recommendations aggregate or where they are absent. And then by clicking the cells which have a number inside them, you can open the actual recommendations. Last but not least, I think it's one of the most important features of the KSP is the mobile app. It is available on these 2 platforms, as you can see, and the apps provide you with content, access to the same content that you have on the website, but also they have some other special features. They can give you a recommendation summary for a quick view of what is the list of actual top line recommendations in each of the guidelines. They also have algorithms. We started using these. This one here shows you, for instance, an algorithm for TB preventive treatment, where the user defines, let's say, the population or the conditions, and then in the end ends up with a decision point. And also there is a dose calculator. There is one for the TB preventive treatment dosage. So again, according to the regimen that you want and the age group, let's say, or weight band of the people, you can come up with a dose or the number of tablets that you need. This, I think you have seen it behind me. We also have a YouTube recording of the launch of the KSP that we did on the 3rd of June, and this is accessible via YouTube. And I think one of the developments that is coming up very soon, later in the coming weeks or so, is an offline version of the app, which is very helpful for people who are in remote areas and have erratic access to the internet, and they can download the document down on their computer or laptop and can run it even when they are offline. And of course, every time it's online, it will synchronize and update content if that has happened. And I think that will be really something which has been requested, of course, after we launched the KSP, and we are able to deliver it very shortly. And that will also provide a sort of app for tablet computers. So it will be available actually in 3 systems, right? Windows as well, and that could help as well many people who are in situations where very often the people who need to use these guidelines are. And with that, I would like to thank many colleagues in GTB who have worked very hard to make these products possible, as well our colleagues in IT and the regions and countries, ADAPT, who produce the knowledge sharing platform, and Inis Communication, who produce the PDFs for the guidelines in the consolidated series, McMaster and Evidence Prime, who have produced the recommendation mapping with us, and KNCV, who has been working on the training modules, and as well our donors. Thank you very much.
Thank you, Dennis. That was an excellent summary of a tremendous amount of work that I know has gone into this. And actually, while you were speaking, I downloaded it. And it looks really good. I congratulate you and your team on putting this together. And just to begin, let me start with a question, because we have plenty of time for some questions. How are you planning to monitor kind of or evaluate the usage of the mobile device is what I'm interested in.
Yeah, that's a good question. So, of course, the stores allow us to have some basic statistics about how it's being downloaded and used, and there is also the same from the website itself. We can monitor sort of what is being done. Of course, we are presenting it in fora like this, so I think we've already had a lot of precious sort of feedback on different components of this. One of them has been, of course, the language issue, because it's mostly in English. So we are slowly preparing. We have already a French sort of environment that is being created. We have one French document which is being put into place. We have the Russian, one example, as well, a Russian handbook that's being put. Again, the production of this offline instance of the KSP has come from one of the presentations that we did. That was given to us. So I think up to now, mostly I would say much of the feedback we've had is like sessions like this. So this is one of the take home that I would like from this session as well, that people give us more feedback.
Thank you. I see we have one hand raised right now. Let me invite Salma Ali. Would you like to ask a question?
Yeah. Hello?
Yes, I can hear you.
Please.
Yeah, regarding KSP application, is it free and updated automatically or not?
So yes, it is free, of course. I mean, it's accessible to everyone, and it is updated whenever we have new material. All of the material that I showed has gone through like the usual WHO process of clearance for guidelines and other products such as this. So it's all the same documents that you would see on our main website, right? That are launched with news flashes, etc. You will also find here. So it's the same content.
Okay, thank you.
Let's see if we have any other chat or hands raised. I don't see any. Well, again, as someone who just downloaded this, it looks really quite good. And I hope people will do what I did and download it and use it. Let me just see if we have any more questions. I have Dennis, one here is, does the mobile app use data or can be used offline? Can you please remind the name of the app?
Yes, so of course you can use mobile data, or else you can use your Wi-Fi to access that. So it works like any normal application. Sorry, what I didn't quite get the second part.
Here, I'm just reading this one. Can just remind the name of the app.
Oh, okay. So if you go in the app stores, you can put WHO TB guide, or else you can just go via these QR codes here.
And we have another, I think we have a hand raised.
I saw Andre for a moment.
Yeah, Andre, would you like to speak?
Yeah, if you don't mind. It's not a question, it's a comment. And indeed, when the demo started to be shared, among the testing users, we thought that this would be a revolutionary instrument for a digital reference provision to the questions which we oftenly receive in the region, despite the fact that it's not fully translated and localized to the Russian language. It maintains its valuable inputs and helps us in the region, in the European region, a lot to provide answers to the country's requests related to the evidence that the WHO is providing. The unique format and the features that helps to merge different references from a different guidances into one kind of stream by providing multiple references is excellent. And so just to reiterate that the tool is quite feasible and helpful in the region. Thank you very much indeed.
Okay, I don't see any further questions or hands raised. So I think we'll move on to the next speaker. Dennis, thank you very much again for an excellent talk. Matteo, I think I'll hand it back to you.
Thank you very much, Chuck. Now we switch gear. We move to the next topic, next session. This is about WHO recommendations on systematic screening for TB disease, as well as on the programmatic management of TB preventive treatment. So two important topics, and we'll try to show how they are interlinked. We will highlight the synergies between these two areas. And of course, we will hear the latest recommendations which have been published on World TB Day earlier this year. We're going to have two speakers for this session. Dr. Cecily Miller, who is an epidemiologist working at the WHO here in Geneva, and her focus is screening for TB and digital innovations. She's really the guru of TB screening here at WHO. And prior joining WHO, she worked for 10 years at the Center for TB at the University of California, San Francisco, where she focused on clinical programmatic research in TB diagnosis and screening. And she will talk about screening guidance. The second speaker is Dr. Avinash Kankar. Avinash is an MD in preventive and social medicine, also medical officer here at WHO in Geneva. His area of work is really treatment of TB infection or TB preventive therapy. Prior joining the WHO, Avinash worked as a WHO field consultant for national TB and HIV programs in India. He's clearly going to talk about management of TBT. I think over to Cecily, if you could start sharing the screen.
Thank you very much, Matteo. And can you confirm you can see my slides?
Yes, please maximize. Yes.
How's that? Okay, great. So thank you. Yes, again, I'm Cecily Miller with the WHO Global TB Program, and I'll give the first part of this talk, and then I'll hand over to my colleague Avinash. And I will present on the current and latest updated guidelines on systematic screening for TB disease. And as Matteo mentioned, I'm sorry. I'm sorry, I'm hearing something. Oh, I guess it's automatically going.
Slides are moving.
Yes, just a sec.
And disactivate the move.
Okay. We'll just start here. So first, I'll just briefly clarify what we mean by systematic screening for TB disease. So by this, we mean the systematic identification of people at risk for TB disease in a predetermined target group by assessing symptoms and using tests, examinations, or other procedures that can be applied rapidly. So the key features of systematic screening differentiated from standard clinical care for TB or diagnostic examination are that it should be done systematically in an entire selected population, pre-selected population. It should be done using a highly sensitive tool to distinguish people who have a higher probability of TB, but then it needs to be followed with a proper diagnostic evaluation using a test with the high accuracy to confirm a diagnosis of TB or to rule it out, at which point other procedures can be done, such as TB preventive treatment, which Avinash will talk about later. It needs to follow established ethical principles specific to screening interventions, which are a bit distinct from standard clinical care. So the objectives of TB screening really work at two different levels. First, there's the benefit that it can provide to the individual, or really at the individual level, by helping to detect TB early or prevent it if it can be prevented through treatment. Screening seeks to increase access to treatment or preventive care, and thus seeks to reduce delays to diagnosis, improve treatment outcomes, and reduce costs to patients, including risk of catastrophic costs. It seeks to do this by really overcoming barriers to care among those who have the least access to care potentially, or the most vulnerable to TB. But screening also operates, of course, on the community level, as we know, by seeking to increase overall the detection of prevalent TB, reducing the prevalence of TB, thus reducing transmission and ideally avoiding future incident TB. So because of these things, it has a role to play in the overall care of TB globally in three different ways. First off, it can help address the global case detection gap, or what we call the missing millions. So we know that in 2019, there was almost a 30% gap in the estimated number of people who were notified with TB, reported to WHO. Out of the estimated 10 million cases, about 7.1 million people were diagnosed and treated and reported. And we know that the COVID pandemic in 2020 has made this situation much worse. And we don't have complete numbers yet, but provisional data show that perhaps an estimated 1.4 million fewer people received care in 2020 than in 2019. And so we know in general, we are definitely still lagging behind in our goals for and our targets for case detection for the UN high-level meeting of 2018, and also for the NTB strategy. And additionally, as I was saying earlier, screening seeks to reach really those who are the most vulnerable to TB, and often those are exactly the populations that have the least access to care. And lastly, TB screening is an essential first step in initiating TB preventive treatment in those populations that are eligible for it. And this is also a life-saving intervention that needs to be scaled up to reach our targets for the NTB strategy in the UN high-level meeting. So briefly, this just shows the patient-initiated pathway on top, which I think we're all familiar with, of how patients can seek care for TB, but only after they have identified their symptoms and navigated the health system, whereby as compared to the TB screening pathway, the provider-initiated pathway on the bottom, which seeks to overcome a lot of these barriers and delays. And again, you see here at the top how TB screening is the first essential step in either finding and treating prevalent TB or initiating TB preventive treatment. So because of these, all of these reasons and roles that TB screening fills in TB care, the WHO first created guidelines for TB screening in 2013. You can see those at the top right there in green, as well as an associated operational guide. But the past several years have seen a lot of new evidence come to light on screening and some new developments in screening tools and technologies. So because of these, last year in 2020, the WHO convened a guideline expert group to examine the latest evidence and update the guidelines and recommendations on TB screening. and the operational guidance, with the goal to bring them in line with the latest evidence and provide as much implementation guidance as possible for specific screening of specific groups and populations. And you can see here where you can access these guidelines, as well as here on the knowledge sharing platform that Dennis presented earlier. All of the guidelines are, of course, accessible there as well. And I will briefly now go over the updated recommendations. So first off, there are two sets of recommendations, one set of which populations should be screened for TB, and one set of recommendations on which tools should be used to screen those populations. So first off, for the populations to be screened, there are now 4 populations in which TB screening is strongly recommended. And this includes, number 1, household and close contacts of TB patients. It includes people living with HIV. It includes minors exposed to silica dust, and it includes prisoners. And all of these are existing recommendations, except that the recommendation for prisoners has been updated from a conditional to a strong recommendation due to the increased risk of TB found in prisons, regardless of the background prevalence of TB. So for these populations, screening should always be conducted globally. The question is just how. So what tools and algorithms should be used? What's the best implementation model for screening? What's the best frequency? And most of these will depend on the specific context in which the screening is being done, the resources available, and other factors specific to the setting. TPT should be provided when appropriate, and we know that these first 2 populations represent the perhaps most important populations for TPT. And monitoring and evaluation should be conducted always to make sure the intervention is having the intended effect and to help inform or any adjustments that need to be made to the implementation model. So next, there are some populations in which systematic screening for TB disease is conditionally recommended, and they include people with risk factors for TB who are seeking healthcare or already in healthcare in settings with a prevalence of 100 per 100,000 or higher. That's basically 0.01%. And this also includes people who have untreated fibrotic lesions seen on chest X-ray. And normally these will be also found in the healthcare setting, and they're often found through screening. And the reason for this is basically that people who already have a risk factor for TB, they could be in healthcare seeking care for another reason, but this is a very targeted and efficient way of increasing screening for TB for people who are already in the healthcare system. Additionally, systematic screening is recommended in populations with structural risk factors for TB and limited access to healthcare. And this includes populations such as urban poor, or we used to call slum populations, homeless communities, refugees and migrants, other vulnerable or marginalized groups. This also includes rural, isolated, or tribal communities. So these populations, as well as the population before, these can apply to a number of different populations or risk factors, and it really depends on the specific setting and the specific vulnerabilities that might be existing in a population, or clinical risk factors that might be most prevalent in a population, to help determine which populations need to be prioritized for TB screening. And we have more description of this in the guidelines. Lastly, the recommendation for screening in the general population has been now updated to include all settings with a 0.5% TB prevalence or greater. This is 500 per 100,000. And this was updated from previously a benchmark of 1% prevalence or higher. And this is due to recent trial data in the last few years that has shown evidence of effective screening to reduce prevalence and reduce transmission in even a lower prevalence setting. So again, in these populations, the consideration before deciding to do screening needs to be given to weighing the benefits versus the risks of screening, considering the opportunity costs for screening compared to other TB interventions and other health interventions, and making sure to prioritize which risk groups represent the greatest burden or have the greatest vulnerability to TB in a particular setting. I'll now briefly go over the tools that have been recommended for screening. Now, in the general population or in high-risk groups, such as household contacts, minors, or prisoners, The following tools have been recommended. These do not apply to people living with HIV. I'll discuss that next. Symptom screening remains a recommended screening tool. We know that symptom screening is not the most accurate tool, but it remains a very feasible, easily implementable, and easily repeatable screening intervention. And it can be adjusted to prioritize either sensitivity or specificity. A number of different screening approaches can be used. Sometimes screening is just done for cough, as we see on the top left icon, and sometimes any one of multiple TB symptoms can be used, as we see on the bottom there. Chest X-ray is recommended as a screening tool as well. It can be a highly accurate tool for detecting TB. It's not accurate enough to be a diagnostic tool, as we all know, but it can detect TB early. And we also see evidence from prevalence surveys that it can detect TB prior to the onset of symptoms, which can really help increase under detection of TB in certain areas and can hopefully help reduce transmission if it can be detected prior to onset of symptoms and coughing. Now, lastly, WHO recommended molecular rapid diagnostic tests. These include Expert, TrueNat, and other tests in this category. They are also now recommended for screening as well. So any of these tools can be used. The question of which tool and which screening algorithm it should be used within is something that needs to be determined by the specific context and setting, goals of screening, and resources available. Now, for the first time as well, computer-aided detection software programs for the automated interpretation of chest X-rays are also now recommended as an alternative to human interpretation of chest X-ray. And this is for TB screening and triage. And this is for all adults aged 15 years and older. And this is also including people living with HIV. This is the first time we're recommending CAD, and we now see sufficient enough evidence that it has similar accuracy to human readers. And this is a very exciting development, as we know this really increases the scope of where screening can be done to areas where trained personnel are scarce. And there are a couple of resources here, down here at the bottom, where you can find out some more resources for CAD implementation and selection of programs. So for people living with HIV, we now have 4 tools that are recommended. The WHO recommended 4 symptom screen remains a good screening choice. It's been recommended since 2011. We also now have chest X-ray recommended as a screening tool for people living with HIV. And this can really help increase the sensitivity of screening above and beyond just the symptom screen, particularly in people who are enrolled in regular ART care. C-reactive protein on the bottom left here is now also a recommended screening tool for people living with HIV. This is a blood-based test that can often be done as a simple point-of-care test on a finger prick of blood. And this particularly has the potential to increase the specificity of screening for people who are newly enrolling in care. And lastly, WHO recommended rapid diagnostic tests are also now recommended for people living with HIV. And in fact, there is a strong recommendation that they should be used for very ill medical inpatients with HIV in high burden settings due to the need for rapid screening and progression with a highly accurate test. So lastly, tools for screening children. There are 2 groups of children in whom TB screening is strongly recommended. They include child contacts of TB patients and children living with HIV. For child contacts, symptom screening and chest X-ray are both strongly recommended. And for children living with HIV, symptom screening is strongly recommended, as well as screening for previous or recent contact with a TB patient. And we hope that in the near future, we will see some more evidence or developments come for the newer technologies and tools for screening for the children, for these child age groups, but we don't yet have it. So I'll briefly mention that in the associated implementation or operational guidance for the screening guidelines, we have a number of different algorithms here. These are just examples. I won't try and walk you through them, just to say that we have a number of different algorithms for all of the different populations that I discussed today. And the algorithms really talk through how all of these different tools can be used and combined into screening algorithms, because now we have a large toolbox, so we have some guidance for how to use them most effectively and efficiently, depending on what the goals of screening are. And lastly, we have a few digital tools to assist with planning and implementation. We have the Prevent TB app, which my colleague Avinash will speak much more about. We have the Screen TB tool, which is a web-based tool to assist countries with prioritizing risk groups for screening and selecting algorithms. And we have online resources for calibrating CAD for TB detection. So now I'll hand over to my colleague. Thank you.
So, thank you, Cecily. I'll share my screen. Please confirm if you see the screen.
Yes.
Yes, please maximize. Put on display or presentation mode, please.
Yes, I'm trying to do that. Is it okay?
Yes, excellent.
Is it presenters mode or?
It's full view. Yes, we see it well. Continue.
Okay, great. Thank you. Sorry for that. Yeah, thank you, Cecily. I'll move on to TB preventive treatment, and this on this slide I will try and draw your attention to the fact that TB preventive treatment is actually part of the continuum, and it's an integral part of the active TB case finding efforts in whatever target population you aim to do TB screening. And individuals who are found not to have TB should be considered for TB preventive treatment. Dennis mentioned TB knowledge sharing platform. I'll just say both the TB preventive treatment guidelines as well as the operational handbook are also hosted on this platform. And that's a good place to get access to this document, which we published in 2020. So this is a consolidated guideline which includes all the previous recommendations on TB preventive treatment. It follows cascade of care approach, and it divides the recommendations into these 4 key steps, starting from the target population for TPT, ways to rule out TB disease, and recommendation on the tests for TB infection, and then the TPT options. Starting with the target populations for TB preventive treatment, and Cecily also mentioned people living with HIV is one of the most important target group, and under that, adults and adolescents who should all be considered for TPT regardless of the ARV status, pregnancy, history of TB treatment, level of immune suppression, or availability of the test for TB infection. Similarly, children as well, infants who are contacts of TB, or children who among whom TB disease is ruled out should be considered for TB. For the second group is household contacts of bacteriologically positive pulmonary TB patients. Children under 5 have been recommended for a long time, and it's a strong recommendation to consider them for TPT. But we also now recommend individuals who are 5 years and above, as well as contacts of drug-resistant TB patients. So we have a recommendation for the first time for these groups as well in high-burden settings. And then the third group, it actually brings together several risk populations, among whom systematic testing and TPT is recommended. And first among them are the clinical risk groups, individuals who are being considered for anti-TNF treatment, or are on dialysis, or are being prepared for transplant, organ or hematologic, or who have silicosis. All of these populations should be considered, and this is a strong recommendation. There's a conditional recommendation as well to consider prisoners, healthcare workers, immigrants from high TB burden countries, homeless people, and people who use drugs for TPT. However, as of now, due to paucity of data, we don't have a recommendation for systematic testing and preventive treatment for diabetics, alcohol users, tobacco smokers, and underweight groups. Moving on to the next set of recommendations to rule out TB disease, and I will summarize this in one table. Unlike the TB screening guidelines, which are to find new TB patients, to rule out TB disease, symptom screen remains the backbone, and lack of 4 symptoms, for example, for people living with HIV, is considered to have very high negative predictive value, and so you can safely use this as a criteria to consider TPT. And similarly for infants and children living with HIV and contacts who are more than 5 years, or the clinical risk groups, where we use different set of symptoms to rule out TB disease. For the first time, we also have a recommendation on use of chest X-ray among people living with HIV who are on ART, or contacts who are more than 5 years of age. And in these groups, absence of clinical signs or abnormalities on chest X-ray should point to eligibility for TPT. We also have, for the first time, recommendation on tests for TB infection, and TST or IGRA are considered equivalent and are recommended to be used as tests for TB infection. However, they are not considered a requirement for initiating TPT among people living with HIV or children who are contacts of TB patients. TPT options, treatment options, there are several now. In the past, we just had daily isoniazid regimens, but now we have 5 real regimens in addition to isoniazid monotherapy. We have 3HP, which is weekly INH rifampicin regimen. We have 3HR, which is isoniazid rifampicin daily regimen, and also the very short 1-month daily isoniazid rifampicin regimen. Single dose rifampicin monotherapy is also one of the recommended regimens. The 36-month regimen continues to be recommended for very high transmission settings, and a bit more on the regimens for children. For children under 2 years, the preferred regimen is 3 months daily isoniazid rifampicin, and the reason being fixed dose combinations and child-friendly formulations are available for this for use in children, and that's why this is a preferred choice. Also in children who weigh up to 25 kg. For children living with HIV, 3HP could be an option, particularly among those who are not on protease inhibitors or nevirapine-based regimen. And in older children, again, 3HR could be a choice, but 3HP as better formulations are becoming available and MDCs are becoming available, could be considered for TPT. As I said, we have a recommendation for contacts of MDR TB patients as well. However, we don't have a recommendation on the regimen as such as of now. There are several clinical trials that are happening, which will guide future evidence. But for now, countries are encouraged to consider MDR TPT for MDR TB contacts, and the pointer is the evidence that was reviewed was about levofloxacin used daily for 6 months along with ethambutol and ethionomide. So this could be a regimen that could be tried, but only after assessing the intensity of exposure and drug resistance pattern of the host case. So these are the 3 clinical trials that are going on, and the results are expected some this year, but 2 important trials will have results later. and after which there would be modification in these recommendations. So 2 of these trials are considering levofloxacin versus placebo use. And in the Phoenix trial, delamanid is being tested amongst all populations, all age groups. So I'll now move on to the operational handbook and just to point out to you what it contains. It provides all the complementary details that you will need for implementation of TPT in the programs. It provides, it touches on several areas like contact tracing, drug dosages, drug-drug interactions, monitoring of adverse events, and there are several sections that would try and answer specific questions that programs or implementers usually have. So I'll just provide some pointers, and the first and foremost is the questions that programs or implementers frequently ask, and the concerns around adverse events due to TPT, or efficacy of TPT, or the risk of drug resistance using single drug or 2 drug regimens. Just to state, the operational handbook collates all the existing evidence till date and provides clear indication on several of these questions. For example, adverse events, we provide all the evidence that states that a very small proportion of people on TPT develop adverse events, and most of them are self-limiting. In terms of efficacy, currently available regimens are reduce the risk by 60 to 90%. They save life and they are protective for a long time, even with a single course. And similarly, there is no real evidence of emergence of drug resistance due to scale-up of TPT. The operational handbook also provides sections like use of TPT in special populations, for example, pregnancy, and it provides pointers to facts that pregnancy doesn't disqualify women from living from TPT. It can be started either antenatal or postnatal. Routine LFTs are not indicated, and then some of the regimens that could be considered, and also the supportive treatment that needs to be considered. So the operational handbook provides such details which should be of use in your advocacy as well as implementation. Moving on further, questions like can THP be co-administered with dolutegravir, and the handbook will provide answers to these questions. How to measure TPT completion? We have several regimens now. Some of them are intermittent, some short, some long. So how do we define treatment completion? And so there are some suggested ways of doing this. Like for 3HP, if 80% of doses are consumed within 133% of the allotted time, then this could be considered a TPT completion, for example. So similar pointers are provided in the operational handbook, and it has a section on planning as well, and things to consider in funding proposals or for costing, like human resources for strengthening contact investigation, and then capacity building, demand generation, which is key for programmatic management of TPT, as it has lagged behind the other interventions. If testing for infection is a national guideline, then there needs to be investments around setting up labs or building capacity. And then management of consumables, recording and reporting system are important investments that is required for this area. And to support this recording and reporting, we have another tool, the Prevent TB digital platform. It's already available on our website, but we are working further to integrate the TB screening elements and updating this application. You can find this app on this provided link. Just to give a few capabilities of this platform. First and foremost, it is built upon the DHIS2 platform. It's free. It can be easily integrated into any national electronic data systems, and it also comes with a smart setup, which enables countries to develop their own application, add or delete their own data variables to capture for the program, it can, and then publish it onto an application which can be used on a mobile device. And there are also various dashboard features that could help in monitoring of the implementation. So this is just to give a glimpse of the smart setup. The smart setup has several features, but just to state, you can add or delete your the variables you want on the application, and without any need from an external service provider. So there are several capabilities that the app provides the national programs, which enable easy modification of the and publication of the app. So this is how the interface looks, the generic one right now, the new version that we are working on integrates all the latest recommendations from the TB screening guidelines. So you can find all the required elements for both active case finding as well as TPT, along with various alerts and training material as well on the tool. So I'll stop here, acknowledging contributions from my colleagues, the national programs, and several other technical partners. Thank you very much.
Thank you very much, Cecily and Avinash. Great presentations. Lots of interesting, content. Very heavy and dense presentations. We are having lots of questions in the chat. Unfortunately, there's no time now to answer them, but please keep asking questions in the chat. Our colleagues here will provide some answers, but we'll come back on those during the Q&A session later on. Over to Chuck for introducing the next session. Thank you again.
Thanks, Matteo. Our next session is updated recommendations on TB diagnosis and treatment. This presentation will focus on the recommendations on TB diagnostics and treatment of drug-susceptible tuberculosis, which is in the newly updated WHO Consolidated Guidelines. The 2021 diagnostic guidelines include new recommendations on initial tests and rifampicin and isoniazid resistance, and follow-on tests for the rapid detection of fluoroquinolone and pyrazinamide resistance. The treatment guideline update includes the use of the 4-month treatment regimen. And this presentation will also provide updates on some of the upcoming reviews planned for drug-resistant TB. And we have two speakers today. The first is Nazir Ismail, who's a team leader in TB prevention, diagnosis, treatment care, and innovation unit at WHO's Global TB Department in Geneva. He leads the team responsible for the development of global policies, norms, and standards in the field of TB diagnosis and laboratory strengthening. Before coming to WHO, he was the former head of the Center for TB at the National Institute of Communicable Diseases in South Africa. The next speaker is Fouad Mirzayev, who leads the TB treatment team of the WHO in Geneva for TB prevention, diagnosis, treatment, and care and innovation. He joined WHO in 2004, and his main area of work has been drug-resistant TB, an area that I've been fortunate to work with him for many years, and access to second-line anti-TB medicines, coordination of multi-country projects to expand access to innovative TB diagnostics. So my pleasure to welcome you both. Nazir, are you going first?
Yes, thanks a lot, Chuck. Let me just make it full screen. Can you just confirm that you can see the full screen and you can hear me?
Yes.
Okay, excellent. Let's get started. So no conflicts of interest to declare. I work for the WHO. My topic is on the diagnostic guideline updates for 2021. And a few just introductory comments around the guidelines. So the first thing is, in terms of the 2021 update, we've moved towards a class-based recommendation for our guidelines, and the latest meetings had basically moved away from product-named recommendations to classes. These classes are defined by the technologies applied, the complexity of the technology, and then the target conditions. The concept of complexity was introduced, and you'll hear terminologies like low, moderate, and high complexity. technologies as a broad term for a class. And these are based on infrastructure, equipment, and technical skills required for those technologies. But we are in a transition phase, so you'll see that some of the previous recommendations around expert and TrueNet still remain as product-based recommendations. But the expectation is that these would basically encourage competition and create a more balanced market. In terms of the updates in the guideline documents, we've broken the recommendations to simplify it for users into three groups. Initial tests for the diagnosis of TB and with drug resistance. The second group is TB test without drug resistance. And the third group is a follow-on test after a confirmation of a TB diagnosis. You'll see that in the latest guidelines, we've updated 3 new classes of technologies, widely expanding the molecular options for countries. The first class that's recommended now is what we call the moderate complexity automated NATs. These are for resistance detection for detection of TB and resistance to rifampicin INH. There were 4 products that were included in this class in the evaluation. It's the Abbott, Roche, BDMAX, and Bruker Heinz systems. What you'll notice about these technologies is that they are generally higher throughput than what we've known before, but also provide automated system from sample to result and share that common feature. So obviously important for the implementation considerations are around making sure that you've got a lab network with a sample referral system in place. But the performance overall, if you look at the TB detection against a culture reference standard, was excellent with expected specificity. So really an excellent tool with high throughput testing. For rifampicin INH resistance detection, on par with what we've seen for other molecular tools, so really keeping up an excellent standard with very good TB detection and a rapid detection. The recommendations for this class, so the recommendations are based on people's signs and symptoms of pulmonary TB, and the recommendations are limited for now on respiratory samples in those with presumptive TB. And importantly, the test not only detects rifampicin, but also isoniazid resistance. So our initial test for both drug resistances up front, and the recommendations is to use this test rather than culture and phenotypic DST. The extrapolation of these recommendations were made for people living with HIV and for children. So these recommendations do apply to both groups. But we have not extrapolated to extrapulmonary TB, as the performance might not be the same, and further research is required. In terms of the next class of technologies, these are what we call the low complexity automated NATs. The first in class for this one here is the Expert XDR cartridge. And you can see the description of the different drugs it detects. So overall, the performance of this test when evaluated for INH resistance detection was also excellent and actually better than we've seen before for other INH resistances, close to 95% against the phenotypic DST reference standard. For fluoroquinolones, also excellent, and then for ethionamide and amikacin, very similar to what is expected. The specificity across the board for all molecular tests has been consistently high. In terms of the recommendations, so for the low complexity automated NATs, so the first in class is the Expert XDR cartridge. The recommendations are for its use in pulmonary TB as an initial test. Importantly, that this is a follow-on test, meaning that it's done among bacteriologically confirmed TB. So whether it is Expert or TrueNet or any other system, or even microscopy for that matter, this test will be a follow-on to detect both INH and fluoroquinolone resistance. Important to appreciate that this recommendation is for not only rifampicin resistant, but also rifampicin susceptible TB, meaning that it could also be used to detect HR TB. And then in terms of recommendations for detection of ethionamide and amikacin, these are recommended for patients with TB and resistance to rifampicin, as those are the situations in which it will be used. In terms of extrapolation, so for this technology, extrapolation was for all 3 subpopulations. So for adolescents and children, for people living with HIV, and the decision was also to extrapolate for its use for extrapulmonary TB. meaning that this, a rapid test for detection of fluoroquinolone resistance, which is a key need in rifampicin-resistant TB, now could also be used for extrapulmonary TB. Just also note that recommendations, although the testing includes other second-line injectables, we specifically only looked at amikacin, as that is the injectable that is included in the regimen table. And then the last class recommended was what we call a high complexity reverse hybridization-based NAT. It's very similar to the current LPA technology. Importantly here, it is the first molecular test we have for the detection of pyrazinamide resistance, so an important step forward to address an important need. The overall performance was really good for both sensitivity and specificity against the culture DST reference standard. But importantly, the recommendations based on the data that was available is limited to bacteriologically confirmed TB, meaning a follow-on test, but importantly as well limited to culture isolates at this stage. So a lot more research around this for direct specimen testing is required. So just to end off quickly, so apart from the guideline updates, which you can find on the knowledge sharing platform that Dennis has highlighted, there were 3 additional forms of guidance that was released in this past year. The first, and importantly, was the catalog of mutations for in MTB and the association with drug-resistant TB. And this is an important landmark piece of work, and we'll have a symposium on the 30th of November to cover this, but the first catalog to provide resistance associations. The second is a technical report on the critical concentrations for DST. And this was an update to the INH and rifampicin critical concentrations. And here, importantly, the critical concentration for rifampicin was dropped, 1 dilution, and that should improve some of the discordances and make the test a bit more reliable for rifampicin detection. And lastly, we just updated the target product profile for next-gen DST at peripheral centers. So with that, thank you very much. I'll leave it back to Fuad to take over for me on the treatment side. Thank you.
Yeah, hi everyone. I'm sharing my screen and hope you can see it and you can also hear me.
Yes, we can.
Great. Thank you very much. In my presentation, in my part of this presentation, I'll try to give you an overview of the current TB policy guidance around treatment, but also provide a little bit of perspective into what is going to happen in the short term. And should have said that I have no conflict of interest, but it was we joined the slides, and that was the slide that was presented earlier by Nazir. So talking about the guidelines on TB treatment from WHO, it is already more than 20 years that the global TB program is developing new or updating TB treatment guidelines and related documents like definitions and implementation handbooks. These guidelines address treatment of both drug-susceptible TB and drug-resistant TB. More recently, probably starting in 2019, the global TB program started process of consolidating these documents because, as you can see, there were multiple documents released at different points in time. And the drug-resistant TB treatment guidelines that were released in June 2020 is probably a good example of that kind of consolidated policy. These guidelines on treatment of drug-resistant TB include chapters and recommendations that are still valid, but also some new recommendations stemming from new evidence, shifting the TB treatment almost exclusively towards all oral regimens, and 2 shorter 9 or 6 month options for certain groups of patients and under certain conditions. The 9-month bedaquiline containing regimen and the BPAL, so-called BPAL regimen under operational research conditions. These documents, the document on the guidelines and in parallel with that, the related operational handbook are both available on WHO website, have been presented and discussed in regional workshops with countries in probably all regions, and available in Russian, Spanish, and French languages. The current recommendations, talking on drug-susceptible TB treatment, the current recommendations are still a little bit scattered between 2010 and 2017 guideline documents. But following guideline developments in this year, in April and June, these recommendations will be updated and consolidated into, in a similar way, into the one document with the content describing regimens of different length in adults and children. And these are regimens of 6-month or 4-month duration, and also other TB patient subpopulations. They will also cover the topics on the dosing frequency, the treatment for HIV co-infected patients, and some aspects on treatment of extrapulmonary TB, like TB meningitis and pericarditis. While talking about the treatment of TB, it is impossible not to mention several other normative and ancillary documents. I would highlight a few, like the XDR, pre-XDR definition, updated definitions, updated in this year, that are already online. The updated outcome definitions for both drug-susceptible, drug-resistant TB that have been unified into one set of the outcome definitions. This year, we will be also releasing the report on the systematic review on first-line medicines dosing, both in children and adults, following the work that was done in collaboration with external partners. The definitions and reporting framework, also an important document that have been first released in 2013, will be updated at the end of this year or beginning of the next year. And also, I would want to highlight the document, so-called the target regimen profiles for TB treatment, the last released in 2016. That will be, we will start the development to update this document very soon. Talking about the new developments, there are some of new developments this and next year that are definitely worth to mention. Some of them have already been announced via rapid communication documents following the guideline development group meetings in April and June this year. Both of those are related to the 4-month treatment regimens for drug-susceptible TB in adults and children. Another development relates to the update of the drug-resistant TB treatment policies. The GDG meeting, the Guideline Development Group meeting, is planned early next year to review new evidence, which may result in new or updated recommendations on use of shorter 9-month regimens and use of BPAL or similar treatment regimens in patients with drug-resistant TB. I think it is important to also note that the emphasis will be made on the operational handbooks and other documents that can facilitate implementation, reporting, or provide direction for development of new treatment regimens. So to list the few, the handbooks that support drug-susceptible TB and drug-resistant TB policy, the definitions and reporting framework, the drug-resistant TB training modules that are being developed in collaboration with KNCV and are about to be released at some point before end of this year. And also the document that I mentioned earlier, the target regimen profiles for TB treatment. So if we summarize, with all the recent developments included, we are moving towards a new mapping of TB treatment regimens with different possible options depending on drug resistance profile, so meaning for drug susceptible, drug resistant TB or any permutations of those, age of the patients, and disease. An overall and welcome trend, as we can see, is towards shortening of the regimens. Probably last but not least that I would like to bring to the attention of the group here is that we are also, it is drug-resistant TB individual patient data platform. So to increase efforts and stimulate research where we are trying to collect the individual patient data and will be enhancing the platform to facilitate access of all external researchers to it. So this global resource could be used for the research and analysis by many researchers, but this resource, the global resource, will continue to be used for WHO guidelines development as well. So I think with this, I'll stop here. And thank you for your attention, and happy to answer question either in question and answer session or if you send the questions in the chat. Thank you.
Thank you, Fuad, and also Nazir. We do have a couple of questions that have come in. Nazir, I see that you answered it in the chat, but I think it's worth just hearing from you. One related to how do you address discordance between phenotypic and molecular cases? If either one of you would like to comment on that.
Yeah, sure. Thanks, Chuck. Yes, I've tried to respond to it in the chat. So I think phenotypic and genotypic discordances do occur, and it depends on the type of drug and the type of methodology used. Obviously, is it phenotypic, solid or agar, and then obviously molecular test. The best guidance I would suggest is to refer yourselves to the Operational Handbook. We have a chapter called Model Algorithms. And within there, all the different types of discordances, it gives you the algorithm pathway, and then what do you do for each case scenario where you find a discordance, for example, for fluoroquinolone resistance or rifampicin resistance. And related to the second question in the chat, I think that's also around when you're ending up with this low positive results and you're ending up with rifampicin resistance. So again, here the algorithms are quite clear around risk classification for RRTB. So obviously we know that prevalence could vary and risk does vary by patient. So obviously if there's an increased risk for MDR or contact, etc., or depending on your geographic setting, then you'd want to treat. But obviously if it's a low risk MDR, then repeat testing would be appropriate. But again, that's covered in the Operational Handbook as well.
Okay, and I would just say, take a look at the chat because you gave us some of the references that you're referring to.
Yeah.
Let's see, I don't see any hands raised right now. I'm looking for any other questions. See if any are coming in on my phone. No. Fuad, I might ask you a question. You know, we're in an interesting time in TB where data is coming very quickly, and just, you know, how often do you plan to update guidelines on the treatment side? Is this something that you have like you're planning twice a year reviews, once a year reviews? Just how often should we be looking for this?
Thank you, Chuck. That's an important question that we also are trying to wrap our heads around. And basically, this we don't try to make this set and regular once a year or twice a year standard process. We rather try to look into the new evidence becoming available. And how we trying to do that is that we kind of actively scanning and stimulating the operational research activities that are happening a lot during this year, but also looking and really observing the pace of all the clinical trial or studies that are registered currently, and looking at the dates where they will be available. For that purpose, we had been doing that internally. We thought also to develop some kind of the web-based open resource where this will be registered. And actually, I haven't mentioned that in my presentation. We're going to put it on WHO website. So all current studies that are registered at different platforms would be summarized and would be available with the indication of when the dates when they are planned to be ending. So that's the way that we're trying to follow up and see when the new evidence will be available, and then we try to be prepared and start planning things beforehand, while also discussing with the researchers, be it all the programs as well. Just give you a quick example that this year to stimulate the new data, also we knew that there are some big clinical trials that promised WHO to share the data. We also issued a public call to get the data from country programs, some programmatic data, because that can be also valuable, especially for boosting the database for the comparator regimens that have been already recommended. So we'll continue doing that, but fully agree that this very dynamic place, we may have more frequent guideline development group meetings this next couple of years, but it's a welcome development. I think it makes it difficult for the national TB programs to continue also updating the national policies, but it's all positive because eventually it brings the new approaches to treatment, shorter, more effective treatments for patients, and helping also health systems to cope with this stress.
Okay, thank you. Thanks. Well, we're up now for a 5-minute break. I don't know if the union has any comments about the break, but the plan is to restart at 2:30, my time or your time.
Yep, we will break for 5 minutes, and I recommend you do not log off, please, from the Zoom meeting. You just turn off your volume or your camera if you wish, and we will reconvene, yes, at 2:30 CET. Thank you. Welcome back. The course will now resume.
Thank you very much, and welcome back to the course. In the second half, we will have 2 sessions and with presentations and one Q&A session. The next session will be about updated recommendations on the management of TB in children and adolescents, as well as on the guidance on TB ethics, equity, human rights, and palliative care. We will have 2 speakers. First one is Dr. Carrighini. She's a team lead at WHO here in Geneva. She leads a team responsible for policy guidance on vulnerable populations, TB, HIV, and comorbidities. Carrie has a background in public health and holds a PhD from Australian National University. She has a vast experience in the programmatic management of TB with a clear focus on vulnerable population and comorbidities. And the second speaker is Dr. Ernesto Jaramillo. He leads a team who works on human rights, social protection, and disability at the WHO Global TB program here in Geneva. Ernesto holds a degree in medicine and surgery, as well as a PhD in health education from London University. He has spent his almost entire professional career in TB, mainly focusing on programmatic management of TB and MDR TB, with a focus on social science research. I now hand over to Carrie to start the presentation.
Thank you, Matteo, for the introduction. I'll just get my screen sorted out here. I hope that you can see that. I'll just put it into presenter mode. Can everyone see that?
Yes, very well. Thank you, Carrie.
Great, thank you very much. And thank you for the very warm introduction. And it's great to be part of this postgraduate course that has a very nice attendance. So thank you. So as Matteo mentioned, I'm going to talk about updated recommendations on the management of TB in children and adolescents. And then Dr. Jaramillo will take over and talk about ethics, equity, human rights, and palliative care. I have no conflicts of interest to report. So firstly, starting with guidelines on the management of TB in children and adolescents. The current guidelines from WHO were produced in 2014. You can see them on the top right. So that's the guide for national TB programs on the management of. Just hear someone speaking, or just let them mute. So that's the guidance for national TB programs on the management of TB in children, the second edition. Now, as you've heard my colleagues just now talking about many of the updated recommendations that are in place now, of course, many of these relate to the management of TB in children and adolescents, and that population is about an estimated 1.2 million people. Now, in terms of updated guidance, we had a guideline development group meeting held in May, June of this year, which specifically focused on children and adolescents. And the evidence reviewed at that guideline development group meeting included 5 what we call PICO questions, population, intervention, comparator outcomes. And those questions are listed there on the slide. I'll go through them in a bit more detail throughout the next few minutes. We also looked at 2 background questions, one on the socioeconomic impact of TB in children, and another one looking at how to engage adolescents in their TB care. So following from this guideline development group meeting in May, June 2021, a rapid communication was published by WHO in August, so not so long ago, and that's the second document that you can see on the right of the slide. And then at the moment, we are in the process of developing consolidated guidelines, as well as an operational handbook, and they are expected to be released later in 2021. Now, the guidelines will contain new recommendations coming out of this guideline development group meeting that we held in May, June, plus other recommendations that are relevant to the management of TB in children and adolescents. So they'll be in one consolidated guideline and put up on the knowledge sharing platform that Dennis described earlier. And then we'll have practical operational guidance in the operational handbook. So I'm just going to go through the updates in the rapid communication, which are the PICO questions that we looked at. Now, one of the first questions that we looked at was integrated treatment decision algorithms. So as people know, various algorithms and scoring systems for the diagnosis of TB in children are currently in use, but these have not been systematically evaluated. There is a large case detection gap for children, and pragmatic treatment decision algorithms are needed to help move these children closer to diagnosis and obviously to treatment. So to answer this question about treatment decision algorithms, which is really an algorithm that incorporates bacteriological tests, radiography, and clinical signs and symptoms to come to a decision to treat, we reviewed an individual patient data set, or an IPD. And in this data set, there were 14 cohorts from 13 countries and just under 5,000 participants. And we looked at the sensitivity and specificity of existing algorithms that currently exist against a pre-specified clinical case definition, and they were compared to a standard of care algorithm, which was the Union Desk Guide that I think many of you are aware of. Now, in terms of the findings from this particular question, the sensitivity of these algorithms ranged from 16% to 95%, specificity ranged from 9%, which was obviously too low, to 89%. The algorithms with a high sensitivity had a low specificity and vice versa. And the Union Desk Guide or the standard of care algorithm had a sensitivity of 65% and a specificity of 64%. So the key update that has been signalled in the rapid communication is that in children aged below 10 years with presumptive pulmonary TB, treatment decision algorithms may be used to diagnose pulmonary TB, but of course, bacteriological confirmation needs to be sought wherever possible, using the available and recommended diagnostic tests, which Nazir has just talked about, and also using appropriate paediatric specimens. And as I mentioned earlier, there will be practical guidance on these algorithms published also by WHO. So that was the first question that we looked at. The second question was about the use of Expert Ultra in gastric, aspirate and stool. So as people know, Expert Ultra is a next generation assay to overcome the lower sensitivity of Expert MTB-RIF. And Expert Ultra is currently recommended in sputum and nasopharyngeal aspirate for the diagnosis of pulmonary TB and rifampicin resistance in children, whereas Expert MTB-RIF is recommended in sputum, gastric aspirate, nasopharyngeal aspirate and stool. So there was a gap with regards to Ultra in gastric, aspirate and stool. So for this question, there was a systematic review, a diagnostic test accuracy systematic review commissioned by WHO, and that review looked at the use of Expert Ultra in gastric, aspirate and stool samples in particular. Now, there were 6 studies included in this systematic review for gastric aspirate with about 700 participants, and 6 studies again for stool samples with just under 1,300 participants, and the studies came from 9 countries. Now, in terms of the findings from this review for gastric aspirate, the sensitivity was 64%, the specificity 95%, and for stool, the sensitivity was just a little bit lower at 53%, but still a higher specificity at 98%. And at the guideline development group meeting, the benefit of detecting rifampicin resistance using Expert Ultra was extrapolated from adult data. So the key update here was really that, just went ahead. In children aged below 10 years with signs and symptoms of pulmonary TB, the evidence supports the use of Expert Ultra in gastric, aspirate and stool specimens as an initial diagnostic test and also for the detection of rifampicin resistance rather than microscopy culture and phenotypic DST. So this recommendation currently complements the existing recommendations. The third question that we looked at was related to treatment. So this was related to treatment shortening, in particular in children and adolescents with non-severe TB presumed to be drug susceptible. And I think many people will know about the SHINE trial that was underway that has concluded. So we reviewed evidence from the SHINE trial at this guideline development group meeting. Now, the SHINE trial is an open label treatment shortening trial in children with non-severe symptomatic smear negative TB. It was conducted in Uganda, Zambia, South Africa and India, and it included children and younger adolescents aged less than 16. So these children were randomized to either a 16-week treatment course or a 24-week treatment course, so the standard first-line treatment, and they were dosed using pediatric fixed-dose combination tablets. Now, at the guideline development group meeting, the primary efficacy outcome that we looked at was death by 72 weeks after randomization, treatment failure and loss to follow-up, and the primary safety outcome was grade 3 or higher adverse events experienced during treatment. Now, the key finding at the guideline development group meeting was that the 4-month regimen was non-inferior to the 6-month regimen. And this non-inferiority was consistent across all of the key analyses, including age groups, HIV status, type of TB, and the level of adherence. So the key update really related to this question was that in children and adolescents under 16 years of age with non-severe tuberculosis, presumed to be drug susceptible, a 4-month regimen composed of 2 months of isoniazid, rifampicin, pyrazinamide, plus or minus ethambutol, followed by 2 months of isoniazid and rifampicin, should be used as an alternative to the 6-month regimen. Now, important implementation considerations were noted to determine eligibility for this shorter regimen, and they will be described more fully in the Operational Handbook. Now, the next question that we looked at was the use of bedaquiline in children with drug-resistant TB, multi-drug-resistant TB, age less than 6. So I think, as many of you know, bedaquiline is a core component of WHO-recommended shorter all-oral regimens and also the longer regimens as a group A drug. It's currently conditionally recommended for children aged 6 years and above. And part of this recommendation has been based on extrapolation of adult efficacy data and PK or safety data from phase 2 trials in children. Now, at the Guideline Development Group meeting in May-June, we looked at data from 2 trials that have used bedaquiline in children. We looked at data from TMC 207 and the Impact P1108 study, both trials in children. We also had an individual patient data set that had just over 24,000 records, a pediatric data set, and the majority of these children were from India and South Africa. Just under 20,000 of those records were then used for a matched analysis of treatment outcomes. So the findings based on this PICO question, obviously we had a very small sample of children aged below 6 who received bedaquiline. It's currently not recommended by WHO, so it wasn't surprising that we had that small number. They were mainly from the trial, Impact P1108. It was found that there were no cardiac safety signals in these younger children, so below 6, distinct from adults. And the PK models from both studies suggested that the adult drug exposures can be achieved in most children. And then in the individual patient data set, there were actually 40 children aged under 6 who received bedaquiline, 68 children aged 6 and above. And bedaquiline was significantly associated with a shorter treatment duration and a lower odds of injectable use. Children under 6 did have a slightly lower success rate, but residual confounding was thought to be likely. And the key update here that has been signaled in the rapid communication is that in children of all ages with MDR-TB, bedaquiline may be used as part of the shorter all-oral bedaquiline containing regimen or as part of longer treatment regimen, so effectively removing the age limit for bedaquiline. Then we had another PICO question on the use of delaminid in children with multi-drug resistant TB aged less than 3 years. Now, the current recommendation is for children aged 3 years and above on longer regimens, so that's been in place since 2018. And that again has been based on partly on efficacy data and also from PK and safety data from trials in children. So in terms of the data reviewed at our Guideline Development Group meeting, we looked at phase 1 PK safety and tolerability data from 2 trials on delaminid, trial 232 and 233. So these are in children in those cohorts that you can see there on the slide. We were particularly interested in children aged 0 to 2 years, so cohort 4. We also had a pediatric individual patient data set, as we did for bedaquiline. So the key findings here were that the exposures in the children aged 0 to 2 were lower than in other children aged 3 years and above. And that meant that a modelling or simulation approach to dosing is needed. When this was carried out, there were no cardiac safety signals distinct from adults. The simulation also suggested that this would be true, that there would be no significantly meaningful QT changes even when the modelled doses were used. And in the individual patient data set, a very small number of children under the age of 3 who were given delaminid, only 7 children. So that was insufficient numbers to do any meaningful matched analyses. And so the key update here is that really in children of all ages with MDR-TB, delaminid may be used as part of longer treatment regimens. But of course, and of course, there's some further work to do on dosing. I'll talk a bit about that later. And again, this removes the age limit on delaminid. Then getting to one of our later questions on treatment, we had a question on the treatment of TB meningitis in children and adolescents. I think it's very clear that TB meningitis is a very serious form of extrapulmonary TB, often with very poor outcomes for children, even when treatment is able to be accessed. The current WHO recommendation for the treatment of TB meningitis in children is a 12-month regimen that you can see there on the screen. And this was based on a literature review carried out in 2009, where a number of studies, 49 studies, were identified in that literature review in 2009. So to answer this question, again, we carried out a systematic review and meta-analysis, and we looked at the effectiveness of a shorter intensive regimen. So that regimen was a 6-month regimen composed of rifampicin, isoniazid, pyrazinamide, and ethionamide, with slightly higher dosing of rifampicin and isoniazid versus the current standard of care, which was the 12-month regimen. So the key findings here, there were very few studies that were able to be included, 3 studies. However, they did involve about 700 participants. For the comparator, we again had 3 studies with just under 300 participants. The death rate for the shorter regimen was 8%. In the standard of care, it was 24%. Treatment success was slightly higher in the intervention regimen at 83% versus 75% with the current 12-month regimen. Neurological sequelae among children who actually survived was 66% with the short intensive regimen versus 36% with the longer regimen. And then survival without sequelae, you can see there on the screen, was 28% for the shorter regimen and 48% for the current 12-month regimen. So the key update here is that in children and adolescents who are diagnosed with TB meningitis that is presumed to be drug susceptible, a 6-month intensive regimen can be used as an alternative option to the currently recommended 12-month regimen. And it's important to note that the current recommendation is actually a strong recommendation. Finally, the final questions that we looked at were related to models of care and to look at models of care for case detection and the provision of TPT in children and adolescents. And we conducted a systematic review to look at this question, and we really looked at decentralized care and family-centered integrated care. And these were brought out because these are key actions in our 2018 roadmap. So we conducted a systematic review here, and we looked at health facility and community approaches, including improving diagnostic capacity at the primary healthcare level and community outreach or screening services. We looked at decentralized services, which can increase the levels of TPT initiation. And some of the findings were that there was positive but limited evidence on the different types of service integration to increase TB case notifications and to also increase TPT coverage. Another finding was that socioeconomic support for families affected by TB can improve the coverage for tuberculosis preventive treatment. So the key finding here is really that in high TB burden settings, decentralized and family-centered or integrated services may be implemented to improve TB case detection and the uptake of TBT. So in this context, though, it's important to remember that decentralized services don't replace the other services, so perhaps centralized or specialized services, rather they complement them. So that's just a brief summary of the main questions that were considered at the Guideline Development Group meeting in May, June. We are currently working, as I mentioned, on consolidating all of the guidelines and the recommendations relevant to the management of children, of TB in children and adolescents. And this slide provides an overview of the different guideline documents from which the relevant recommendations will be sourced. So it includes TB prevention and screening guidelines, the BCG position paper, guidelines on rapid diagnostics, which Nazir has talked about, guidelines on the treatment of drug-resistant and drug-susceptible TB, which Fuad has talked about, and other guidelines on HIV and nutrition. So just to summarize and to finish, the next steps for us are to move forward with publishing consolidated guidelines on tuberculosis and an associated operational handbook, which we're working towards this year. They will later be translated into French, Spanish, and Russian. As mentioned, we'll also be releasing an operational handbook, which will contain additional implementation guidance. So it will include information such as how to use the treatment decision algorithms, eligibility for the shorter treatment regimens for children with non-severe TB, how to build an MDR-TB regimen, and examples of models of care. We're also conducting a couple of expert consultations to follow on from the guideline development group meeting, one which we just held last week. So we are going to look further into the dosing of bedaquiline and delaminid, as well as dosing for the shorter intensive regimen for TB meningitis. And we just held a classification meeting on the intrathoracic TB in children. And of course, once we publish the guidelines in the handbook later this year, we will work on dissemination efforts. So as Dennis mentioned, all of these recommendations will go up onto the WHO TB knowledge sharing platform, and we'll disseminate the information through various meetings and fora. And finally, we'll also be developing training materials, but they won't come until 2022. And I think that's it. Over to Ernesto. Thank you.
Thank you, dear Carrie. I want to share my slides. Briefly, I want to focus on the big picture we have for the next 5-7 minutes. I have no interest to declare, and I would like to remind you, everybody, about the core principles that we have in the NTB strategy, which include human rights, ethics, and equity. We have published a guidance in 2017, which have been upheld by the political declaration of the UN General Assembly, and subsequently also emphasized in the report that has been produced following the UNGA declaration. So human rights is a core issue for the work on tuberculosis, and we are working towards ensuring this is really in the driving seat. And while we are updating some of our guidance, we are relying on those documents that have been produced by the organization. There are three major human rights issues that we need to ensure that are really reflected in the work we are doing throughout. Right to health, for which the NTB strategy makes very clear pillar 1 particularly, but also right to social protection, and more recently, the right to access to internet. Social protection, particularly universal health care, fundamental in order to achieve the targets of the NTB strategy, and social protection is definitively, the evidence is piling up as an essential component to add to the efforts on diagnosis and treatment. In the same direction is the emerging right to access to internet, for which the Human Rights Council of the UN has been producing specific statements since 2012, and the more recent just a couple of months ago. One concrete example, in addition to what Kerry has presented on childhood TB, is about palliative care. Why we are so much focused on ethics, equity, human rights is because people affected with TB are everywhere, the most vulnerable population. And those who are suffering because of the disease, the treatment, in the case of tuberculosis, should not be left off the support of interventions that can relieve that suffering. And that is overall the focus on palliative care, for which the World Health Assembly issued a resolution in 2014. let's keep in mind that the idea of palliative care is something not instead of treatment, but in addition to treatment in order to relieve the suffering people are experiencing. Here you have a collection of the most recent guidelines that WHO has produced, particularly in 2018 and 2019, that go through the whole area of work that has to be prioritized. That includes the monitoring and evaluation through the Atlas, the planning and programmatic management for collaboration and integration of tuberculosis programs with palliative care services, never mind the level of development many of them have, particularly in high TB burden countries, and includes, for example, a specific guidance for integrating palliative care and symptom relief in pediatric populations. And more recently, we have also a guidance on the primary health care services fully integrated with palliative care. You have the QR codes that will enable you access to the full document and the websites where this document can be explored into more detail. I'm not going to, in the little time left, to exhaust you the details of these different documents, but it may suffice to say that when it comes to eligibility, we cannot afford anymore that mortality in tuberculosis is used only for advocacy purposes without ensuring that people who are in need of relief of care and end-of-life care do receive this. So the need to systematically assess who are in need of this can help to support the achievement of the NTB targets and the vision of the NTB strategy. When to provide them a palliative care, as I'm saying, is not instead of treatment, but in addition to the treatment that people are receiving. And here there is a non-exhaustive list of the key interventions that you should be considering when supporting people affected with TB. I highlight the element of infection control because quite often people who are particularly in need of end-of-life care may continue being a source of transmission, may not be in need of hospitalization, and because of that, the conditions at household level require infection control fully integrated into the measures to reduce the suffering of the people. This is really a very short summary with the take-home message that we need to ensure human rights really is fully implemented throughout the different components of the NTB strategy based on sound ethics. And that means that we need to look for who are those vulnerable populations because of that condition are less likely to receive timely care and good quality of care throughout the spectrum of their needs. Thank you. Over to our chairs.
Thank you very much, Ernesto and Carrie, for a very rich presentation. I don't think we have time for questions, but I invite everyone to write a question in the chat, and we'll take them in the Q&A session in a few minutes. Over to Chuck for the introduction, the last set of presentations.
Thanks, Matteo. So all this incredible work and development of guidelines is being done for our programs and for our patients. So what better way to end with this last lecture, which is to hear from a national TB program, in this case, the Ukraine, and also the community perspective. So we have two speakers today that will address this. The first, Yana Perliba, is currently the head of the national TB program in Ukraine. She is a qualified pediatrician, has some additional specialization in organization and management of health protection. She's been working in TB for 15 years and since 2012 has been working at the national level. And at one point was the grant manager for the Global Fund for Ukraine. The second speaker is Mike Frick. He co-directs TAG's tuberculosis program, where he leads the TAG's advocacy program. He holds a degree in international studies from Kenyon College in has a master's in global health and population from Harvard School of Public Health. So two perfect people to provide us with the program and patient perspective. Jana, would you like to share your screen?
Good afternoon, dear colleagues. Please confirm that you see the presentation.
Yes, we do.
Okay, thank you. I have no conflict of interest to report. Ukraine is one of the countries in the world with one of the highest burdens of drug-resistant tuberculosis. Despite the notable progress achieved in the fight against tuberculosis, Ukraine still faces a variety of significant challenges exacerbated by the HIV epidemic, the spread of COVID-19, and insufficient treatment results, which is happening against a background that the country's income level is below average. The country continued to receive international technical assistance from the Global Fund grant to accelerate a decisive response to tuberculosis, introduce innovative treatment methods, and build a sustainable system capable of effectively managing the challenges associated with TB treatment. Urgent involvement of existing approaches and the introduction of new instruments in line with updated WHO policies can change this situation. This requires a substantial revision of TB policy and subsequent formation of a new management paradigm, as well as national use of available resources and opportunities of international technical assistance.
Jana, can I interrupt? I don't see your camera on it. I thought it was working earlier. There you are. Okay, thank you.
Okay. The timely and appropriate adoption, implementation of new improved technologies of TB control does not always go smoothly, and the country still faces many significant challenges. The main barriers that Ukraine encounters is the process of implementing new WHO recommended policies include the following: complex bureaucratic process of updating the regulatory framework, financial constraints, insufficient human resources, and the large size of the country, which requires the involvement of a significant number of clinicians, service providers, and the fact that the extension of best approaches across the country may take some time. Clinical practice guideline. One moment. Clinical practice guideline, clinical protocols, and standards of healthcare, including the patient's routes, are considered key tools to improve the overall quality of care. This makes it important to quickly regulate the new guideline recommended by the WHO. As of today, Ukraine has already approved clinical guidelines which contain all WHO latest recommendations. We are grateful to the experts from WHO, Stop TB Partnership, and other partners for the technical assistance provided. Many countries go through a lengthy bureaucratic process of approving or updating national standards or patient management in accordance with the WHO guidelines. This stage is still the most time wasting. In order to speed up the application of WHO international guidelines, the Ministry of Health of Ukraine has approved an order that allows Ukrainian doctors to apply the WHO guidelines that are translated into Ukrainian. However, it is also necessary to obtain the patient's informed consent. How does it look like in the practice? The National TB Program provides translation of new WHO guidelines, distribute it to TB managers, clinicians, partners, patients, and provides clarifications if needed. Thus, during a month after the publication of WHO guidelines, we facilitate their translation and doctors can apply modern approaches to patient management. At the same time, a working group under Ministry of Health is developing clinical guidelines and clinical healthcare standards. The possibility of applying WHO guidelines in Ukraine is a unique practice. It first of all benefits the patients, but also the clinicians and the healthcare system in general, as new WHO recommendations are evidence-based, more effective, and therefore helping saving the lives of many Ukrainians. However, this approach is mainly used in the translation press, while Ukrainian develop and approves national guidelines and healthcare standards by adapting WHO guidelines in the country context. In addition to the healthcare standards, SOP and patients' clinical rules remain to be important tools. For clinical protocols to be effective, the respective recommendations should be consistent with other legal and administrative instruments that are practiced within the existing healthcare system. Medical products recommended in clinical protocols have to be included in the list of state-funded medical products. Consistency with the procurement system, it is crucial that procurement can be adjusted with the introduction of treatment innovation. Consistency with the package of services guaranteed by the state, and clinical protocols should be synergistic with other levels in the healthcare system that support the change of behavior. Plans for implementation of standardized medical care should ensure that clinical protocols are designed to suit the end user. A dissemination strategy, we use, among other things, a mail newsletter, social network, a training plan. We conduct training mainly remotely. For this, the National TB Program has developed a special platform. Determination of indicators that demonstrate the implementation, and a plan for measuring these metrics, and a message for providing feedback to end users, and the process of ensuring timely review and update of clinical protocols. It is important to create opportunities for consultative dialogue with stakeholders, including Ministry of Health, NGOs, affected communities, etc. The essential components of a progress for adoption new tool of national policies. Stakeholder participants in the development of recommendations and policies, analysis of the need and evidence for change, analysis of the risks and benefits of new tools, including the assessment and of options, analysis of health system environment and capacity to adopt, introduce, and implement new tools, development and endorsement of new recommendations and policies, their wide dissemination. The ability to rapidly develop and appropriately use new tools as they become available is critical to saving lives. It is required concentrate and well-planned efforts by the national TB control programs, technical partners, communities members, and civil society representatives, product developers, donors, and international organizations. It is necessary to strengthen and improve management capacity that is prepared for grasping new opportunities and tools and apply them optimally to assist thousands of TB patients, their families, and communities. The improvement of TB care services requires rapid application of new tools recommended by the WHO that accordingly will allow to address current TB control issues while strengthening TB. Thank you for your attention.
Thank you, Jana. Now I think we'll be hearing from Mike Frick a video.
Hi, I'm Mike Frick with the Treatment Action Group TB Project. I'm very happy to join this Union Conference course on new solutions for TB management during and after the COVID-19 pandemic, organized by the World Health Organization to look at updated WHO TB recommendations. My contribution to today's class is really giving a perspective on how community and civil society use WHO guidelines and what we're doing to promote the rapid adoption of new approaches to TB management based on those guidelines. I'm going to turn my video off so that you can see the slides unimpeded that follow, but it's great to be here. So what I want to talk about is 4 ways in which civil society uses WHO guidelines in the work that we do, and taking mostly the WHO TB preventive treatment guidelines as an example throughout, since these are the ones that I use the most often in my own work. And those 4 ways that we use WHO guidelines is first to take them and break them down into key messages and actionable priorities for key populations. There's also the work of communities to build treatment literacy around WHO guidelines and TB management and new tools. There's the work that communities do to ensure that WHO recommendations enter into practice through person-centered care delivery models. And then, of course, WHO guidelines set international standards that inform and bolster campaigns to hold governments accountable for taking national guidelines and bringing them into concordance with the WHO standard. So to take that first scope of work, breaking WHO guidelines down into key messages and actionable priorities. One example of this is Treatment Action Group's Activist Guide series, whereby we take each WHO guideline that comes out and we develop what we call an activist guide, which is meant to take that guideline, the interventions that it discusses, the recommendations that it makes, and distill it into key messages that community advocates need in order to do their work. So the WHO guidelines on TB preventive treatment became our activist guide to rifapentine for the treatment of TB infection. The WHO guidelines on drug-resistant tuberculosis became our activist guide on treatment for drug-resistant TB. And we also have an activist guide to TB diagnosis based on the WHO standards. We'll shortly be publishing an activist guide on shorter TB treatment once the WHO completes its review of the 4-month TB treatment regimen and a possible shorter regimen for children. The goal is really to equip advocates with the information they need to advocate for the uptake of WHO guidelines in their context and support understanding of guidelines among communities. And to give you an example, I want to just look briefly at our activist guide to rifapentine and how it's structured. I'm showing you the table of contents here. We do start with a kind of quick review of the efficacy and safety of the recommendations and new tools being discussed. The real meat of the activist guide, though, is the section that we refer to as the What About Me section. And that takes the international recommendations and applies them to specific groups of people that are likely to be involved in advocacy around guideline change nationally. So for the rifapentine guide, we ask and answer the question, how do you use 3-HP and 1-HP if you're someone living with HIV? What considerations do you have to keep in mind? What about children and young people? What about 1-HP and 3-HP for pregnant individuals or people who wish to avoid pregnancy? Can you use these regimens if you have hepatitis C and you're considering treatment for HCV or liver disease? And can you use these regimens if you're someone who uses drugs? It's really meant to kind of personalize the guidelines and the evidence for the intervention in that specific group so that people can see themselves in WHO guidance. After that, we also talk about access considerations, not only price, but also supply. Who makes the intervention or tool? What do they sell it for? Are there any intellectual property barriers at hand? Where is it available and not available? We basically want to highlight access challenges so civil society can rally around these for a solution. We also have a section called Take Action, where we have key advocacy messages and things that sort of provide a roadmap for advocacy over the next 2 or 3 years as we work to implement a new WHO standard. And because these activist guides are used by people in the community who are advocating for change in their context, we know that they're going to get lots of questions. And so we take common or frequently asked questions from the community and provide answers to those. So the users of the activist guide are equipped with everything they need to answer these questions when they inevitably come up. And because there's often inertia about changing guidelines when new ones are released, the process of change can be slow, there can be resistance to doing something new, we always end with what we call excuse response, where we marshal the evidence needed to overcome common reasons for not acting on a new WHO standard. Our activist guides are available in multiple languages, and we're always taking translation requests and trying to increase their accessibility and reach. And this is really kind of a signature piece of the work that we do to support civil society to advocate for the highest standard of TB care. The other way that the WHO guidelines are used by civil society is the work to build treatment literacy in communities. And this is really about ensuring that communities understand, own, expect to receive, and demand access to the best available tools for preventing, diagnosing, and treating TB. And a great example of this work comes from the Coalition of Women Living with HIV/AIDS in Malawi, which has been instrumental to building the understanding of new TB preventive treatment regimens like 3HP, as the government of Malawi has begun to introduce those as an alternative to isoniazid preventive therapy in the national program. And so this slide gives you quotes from 3 members of COLA who have either taken 3HP themselves or been involved in teaching others and counseling others about the benefits of 3HP, how it compares to earlier options, what advantages it may have, how it's different from other interventions that may feel familiar, like cotrimoxazole. And this is really, I think, critical work. And you can see from the quotes by Elizabeth and Margaret and Rose, the power of taking the time to explain an intervention to community so that they understand it, own it, talk to each other about it, and begin to ask for it. So I really commend the work that COLA has done on 3HP. And it's just one example of why treatment literacy is so important for putting an international standard into practice. The third kind of area of work is ensuring that WHO recommendations enter implementation through systems that are person-centered. And here the work I want to highlight comes from the Zimbabwe National Network of People Living with HIV, ZNP+, and the Jointed Hands Welfare Organization in Zimbabwe. They have really worked hard to integrate new TB preventive treatment regimens into person-centered differentiated service delivery models of HIV care. So ensuring that a person with HIV who's also taking TPT can receive it in a way that is familiar to them, that works with how they refill or receive their ART medications. The photo here is of expert patients from ZNP+. They basically exist to answer questions about new regimens or interventions that community members may have. They can also participate in observing how implementation is going in clinics and facilities as treatment observers. And ZNP+ has talked about how they want TPT to be well synced with existing DSD models of HIV care in their community, including community ART refill groups or fast track conventional or club refill models, whereby people refill their ART and hopefully at the same time can also receive their TPT medications. During COVID-19, they created a People Living with HIV Situation Room with a toll-free phone line where people could call to ask questions about treatment, continuity of service, and get other issues sorted out. Jointed Hands Welfare Organization has piloted something really interesting that they call morning hour talks, where people who are in clinic waiting rooms in the morning waiting for their appointments have the opportunity to hear about TPT regimens in a kind of morning hour talk while they wait. So there's lots of creative ways in which communities ensure that WHO standards are person-centered in how they're implemented and interpreted. And then the fourth area is really the way that civil society does advocacy around WHO guidelines. And for me, this is really about aligning national and international standards. And it's an issue of human rights. We all have the human right to enjoy the benefits and applications of scientific progress. And this is closely related to our human right to enjoy the highest attainable standard of health. The UN Office of the High Commissioner for Human Rights has said that governments have a duty to make available and accessible to all persons without discrimination, especially to the most vulnerable, all the best available applications of scientific progress necessary to enjoy the highest attainable standard of health. We know that WHO guidelines set international standards that basically define that highest attainable standard of health based on the scientific evidence and applications at hand. And therefore, governments have an obligation to ensure national guidelines at a minimum reflect international standards as set by WHO. The ability of civil society and communities to hold governments accountable depends on understanding WHO guidelines in the first place. And to that end, we have published materials that are meant to bring clinical standards and public health guidelines into conversation with human rights law and human rights entitlement. And the example here is our Know Your Rights Guide. A really good example of this accountability work to make sure that international standards are reflected in national policies and laws is the Stop TB and MSF Step Up for TB report, which produces dashboards looking at the extent to which international TB policies have been incorporated into national policies. And so you can see how your country is doing on very specific matters of TB policy and guidance. The dashboard model complements other tools civil society uses like policy reviews, or what some of my colleagues call policy proofing, where you take a national guideline that may be new and you read it against the WHO guideline, see where it's the same, see where it's different. Where it's different, that may be a place where you need to do some advocacy. There's also shadow reporting, community surveys. There are lots of means by which civil society will try to ensure that national standards reflect that international standard that defines the highest attainable standard of health. This accountability work is really critical, and I think it's worth reflecting on where we go next. And here are some ideas from TB civil society. I think we're interested in the extent to which we could set time-bound targets for updating national guidelines after WHO releases new guidelines. For example, could we say within 6 months or a year of new WHO guidelines, we expect countries to have updated their national guidance, really create a time-bound target. That would allow us to do really detailed tracking and accountability work. Could we set a standard whereby when WHO guidelines are released, they are actually released together with 1 or 2 countries that have already updated their national guidelines to reflect the new WHO guideline as soon as it comes out? These would be pathfinder or vanguard countries that really take political ownership over normative change. I think that would be an incredibly exciting possibility to have countries work together with WHO in real time to do this work and show others the way. There's also, I think, a lot of progress that's been made on alerting civil society to scheduled guideline updates. And this is really important because it allows us to plan our work. If we know that a new intervention is going to be implemented or recommended, we can begin before that recommendation comes out, addressing potential barriers to implementation, whether that is overcoming intellectual property obstacles through patent opposition or patent review, whether it means engaging suppliers to ensure that manufacturing is in place, or pushing our governments for commitments that they will take up the new WHO standard without delay. So these are just some ideas to reflect on in the discussion for today's course. And I really appreciate the opportunity to address this issue. WHO guidance is critical for so much of not just the work that TB programs do, but also the activities of TB communities and civil society. And our support of this work is, I think, absolutely essential as we think about how to drive forward to TB elimination. So thanks for the time you gave me, and I'm happy to connect or to answer any questions after the course. Thanks.
Okay. Two excellent discussions. We're now ready to move into a Q&A period. We have plenty of time, it looks like. I'm going to ask you just to raise your hands because we have time to listen to your questions. I think we've covered most of the things in the chat. Look like they have been addressed, although there are a few we may pull out and discuss a little bit more. So we didn't have a specific period set as time for questions of this last session. So I think we should start with that. And I see one already in the chat, and I'm going to ask Matteo. Why don't you ask Jana that question?
Thank you, Chuck. Yeah, it's a great presentation, Jana, and really enjoyed, going through your slides today. The question is what do you think we could do more or better to help you in your work in the country to adopt the WHO guidelines? We have seen the barriers that you have described, and if there is anything that comes to mind, what could we do better? It would be very nice to know. Particularly when it comes to guidelines development, is there anything that we could improve on our work?
Jana, would you like to address that?
Dear colleagues, thank you for your questions. Important to involve experts of WHO to build a country dialogue with involve the expert of Ministry of Health, NGOs, the patients organization, and move to innovation to adapt with country context. And we understand that training for clinicians, patients organization, it is very important under umbrella WHO organization.
Thank you very much. Thanks a lot.
So again, any hands, any questions about any of the sessions today to any of the speakers? And for some of you who may have asked a question and gotten an answer, you may want to hear a little bit more about it, and we can bring that up. So I do see one. And Salma Ali, would you like to speak?
Yeah. First of all,
Your sound is cutting out. Salma, we're not hearing you. Salma, can you hear me? Well, if there are any others, we'll hopefully get Salma back.
For about the informative webinar, and yeah, I have two questions. First of all, what are the specificity and the sensitivity of the C? Hello?
Yeah, we're having a hard time hearing you, Salma. Maybe you should use the chat because we're not able to hear you.
Hello?
No, I think it's not.
You can't hear either. Okay.
No.
Yeah. So Salma, try the chat, and we'll try to address your question. But while we're waiting, any other hands? While we're waiting, then there are a few things that I think did come out and got answered, but maybe could be explained a little bit more. It's so hard to do it in chat. One of the ones very early on, which I think is important question, is for Dennis. Dennis, are you on? There was a question about how the digital information that you presented is different than previous things like the compendium. And I think that was an important question that might confuse people. Could you try to address that and make it clear how they differ?
Right. Thank you very much, Chuck. Yeah, so a few years ago, we had this compendium document that we put together actually to address the issues about consolidation of the guidelines and also to have a sort of place where people can go and find something similar to the standards of TB care that are usually that are updated every so often. And that document contained not just guidelines, but also the handbooks that were available, also like guides on how to do surveillance, the global TB report. That was a time when, you know, there was no consolidation yet. There was the process of disseminating documents via apps was in its infancy still for WHO. So things have moved since then, and we have separate sort of routes now. The KSP is really focused on policy documents and recommendations made by grade and their associated handbooks and training modules eventually. So that is the main portal. And then there is another portal now, of course, since a few years for the Global TB Report, right, which has an app, and that app will be updated soon, actually in a few weeks, with the new Global TB Report findings. So things have sort of been a bit more sort of compartmentalized now on where you go to get the recommendations of WHO, that's KSP, and the information, that's the app for the Global TB Report.
Okay, thank you. So I think Salma was able to type in her question. This is about the screening tool with CRP and HIV patients and in COVID TB patients and screening tools for COVID TB patients. Cecily, do you want to address that, or Avinash?
Hi, sure. I'm trying to see what the exact question is in the chat. I'm not seeing it yet.
Is
it about
specific? Yeah, it just says about screen tool with CRP and HIV.
Okay.
Patients. Maybe just review how that's used or the data to support
Sure.
it.
Yes, so data was reviewed for the screening guidelines on CRP as a screening tool for patients living with HIV. And it was found to have adequate sensitivity and specificity. As has been noted, I think before in earlier questions, CRP is a sort of by definition, a non-specific test. It's a general marker of inflammation. However, data from relatively high TB burden settings did find that CRP actually did improve upon the screening accuracy of just symptom screening alone for people living with HIV. And again, in particular, it improved upon the specificity for patients who are not yet on ART, so who are newly enrolling in care. We don't have yet data on how it works specifically in COVID patients. I don't know if that was the question. So anyway, I mean, I think that can change the spectrum of disease, obviously, and we'll have to see how that affects screening processes. But it is now a recommended tool for screening people living with HIV.
Okay. Okay, thank you. So we have a hand. See, is Sangeeta Sharma? Would you like to comment or ask your question?
Yeah, if you allow me, yes, please. Now my question is for the scanty samples if on Expert Ultra. The sample is not available for phenotypic DST, that means culture. This is especially true for EPTB samples. So is there a guideline which is there for new patients? I'm talking of new patients where the ultra shows MTP detected low and RIF resistance. So do we start the drug sensitive regimen or do we go directly to the DRTB regimen?
Okay, But we should ask Nazir, would you like to weigh in on that?
Yeah, so just to confirm, the question is about TB detection or drug resistance, because for TB detection, it's quite clear. Is this specifically?
No, it's for both.
For
you know,
both.
extrapulmonary TB samples. I think if you remember, I had asked you this question when I'd organized that workshop also, you know. And this question still remains clinically viable, because we frequently face this problem, especially for extrapulmonary TB samples. You know, Expert Ultra is now one of the recommended tests, which we also under the NTP are going to adopt. But the problem comes when Ultra also shows MTB detected low and RIF resistance, and there are no high risk factors.
Okay.
So what to do in that case?
Okay, so clear. So low or trace doesn't really matter. So if it's a positive for extrapulmonary, you can regard it as a true positive for TB, right? So the decision to start TB treatment would be valid, especially for extrapulmonary, right? So that's quite clear. The issue of rifampicin resistance and whether it needs to be a drug resistant regimen or drug susceptible, right?
Yeah.
That would be, if you look at the algorithm that we've advised, is based on risk factors. So if the person is a new case rather than a previously treated would be treated for drug resistance. If there's a contact, it would be treated as drug resistance. If not, I would recommend it be treated as drug susceptible TB, right?
This is precisely what we are also recommending, So if it's a new patient without any risk factors, I always say go ahead with the drug sensitive TB regimen and you follow up your patient, your child.
Yes, exactly.
And then, if the child is not improving, then obviously it becomes a presumptive DRTB, case. And then you can, repeat the tests. Yeah.
And that's in the algorithm. If you just look at the algorithm in the implementation guide, the RR pathway actually splits it by the 2 questions, and then it's addressed in that manner.
Yeah.
Okay.
Yeah. Can I ask another question, if permitted?
Yes.
Which I put in the chat box. Now, the thing is regarding the, because I being from India and also being the co-chair of the National TB Elimination Program of my country, Pediatric TB Expert Group, to recommend 4-month regimen versus 6 months, especially when you do not have any follow-up data in a high burden country, is it justified? I mean,
Carrie?
my question, Yeah,
Carrie, do you want to address that?
Yeah, sure. So thank you for the question. I'm not sure if it's related to the TB meningitis regimen or the...
that's the other question. That's another question which I posed upon, because now we are looking at more of DRTB, TBM. So, and obviously starting with the BDQ regimens, we have already taken up the BDQ based shorter as well as longer regimen, and TBM obviously goes towards the longer BDQ based regimen. So that's another question regarding the replacement sequence. But the first question is the 4-month versus the 6-month regimen for drug sensitive TB.
Yeah, sure. Yes, so thank you for the question. So I spoke about the 4-month regimen for children and younger adolescents. So for that regimen in particular, the results came from a trial, and the relapse rate for the 4-month regimen was 1%. For the 6-month regimen, it was 0.7%. So there was no difference in the relapse when comparing the 4-month treatment versus 6 months for treating children with presumed drug susceptible non-severe.
So the relapse rate, the children were followed up for how long?
72 weeks.
Sorry?
72 weeks.
Okay.
Yeah. And I put in the chat as well for the TB meningitis regimen. This is slightly different because it wasn't a trial, it was a systematic review. So it was just looking at the published literature. And in one of the intervention studies where they used the 6-month regimen to treat TB meningitis, only in one study was there 2 years of follow-up. And in that 2 years of follow-up, there were no relapses, but that wasn't able to be compared to the comparator regimen because it was a review and those data weren't available from the comparator regimen.
Okay, okay, that's great. Thanks.
Okay, thank you. Thanks.
Okay, thank you. There's an interesting dialogue going on right now in the chat that I think is worth some discussion. And Nina, you brought it up, and I don't know if you're able to maybe speak with us and ask the question, and then we can see who can best answer it.
Hello, good day. I'm Nina Castillo Carandang. I'm a health social scientist from the Philippines. And I actually wanted to be provocative today by also addressing the elephant in the room. We do appreciate international assistance, but it is also resulted in reliance on such assistance. How can we ensure that governments actually invest sufficient resources when international resources are coming in anyway? So we do need the international assistance, but it's also fostered, if you want to call it, some sort of dependence. And governments aren't investing enough of internal resources or even allocating the budgets. Christian has reacted to it, and Dr. Avinash. My other question is, how do we measure the success of all of the advocacy efforts, all of these ministerial meetings? I don't really see how it's going, because I've seen it in my country. We've been very dependent on foreign assistance to get our TB program going. I do work on adult and pediatric tuberculosis. Thank you.
Thank you, Nina. Christian, I see you responded. Would you like to add to that? Or?
Well, it was actually, what I wrote is rather a dilemma. I mean, if you make a condition that you support the country if the government supports, but then you have a big problem if the government is really non-responsive to TB, then the TB patients are kind of completely abandoned. So I think that's also not the way to move forward, but there might be some incentive for the government in a more clever way than what I wrote. Thank you.
Okay. And then Avinash, WHO, anything you want to add to that? I see you responded.
No, I mean, I just wanted to say we do our bit, both at the country level, at the regional level, global level. We try and get buy-in from the highest levels in the governments. The way we sort of measure it is by requesting national programs to share the investment data, and it gets published in our global TB reports as well, which provides comparative between domestic versus donor funding as well to an extent. But this is an important question, and I think it needs a collective advocacy, and that, to me, that's the only way we can. And probably we are not in a position to force governments, but some donors do that. Like Global Fund asks for some amount of investments from the government before they can access the Global Fund money. So there are ways in which governments, the donors deal with this as well. But again, it boils down to the advocacy with the highest levels in the government.
Okay, thank you. Matteo, I see you have your hand raised.
Yeah, no, just to step in this discussion, which is extremely interesting. I think some insights to answer this question could come also from Mike Frick's presentation. And when he talked about the role of, the importance of the human rights to health and the importance of patient communities and advocates to stimulate basically governments, and this is clearly a collective action. There is a role for WHO, a role for the civil society, and it would be also nice to hear from Jana, for example, who has been quite successful in adopting some of the WHO recommendation in Ukraine, and it's a difficult balance, and it would be nice to hear directly from someone who has been able to go through this process and get this recommendation adopted.
Let's see, Jana, would you like to comment on what it's been like from the country perspective?
Thank you for your questions. There are many more opportunities for diagnostic and treatment of tuberculosis today. And it is important to set ambitious goals for countries to quickly implement them. And many thanks to WHO team for their systematic work to update the clinical guidelines for countries. And we're ready to continue to make efforts to implement them. And in previously questions about donors' input, I think that donors have to form special conditions for countries in order to get assistance. One of such conditions can be state funding in sufficient amount. It is also important to have support from partners in advocacy to allocation of state budget.
Okay, thank you.
Thank you very much.
So we have a few more minutes left. Do we have any other questions from our participants or from the panelists? One of the things that was coming up frequently, and we didn't have time to have a Q&A, which was on the screening and TB prevention. There were a number of questions that were popping up, and I wonder if maybe we could address a couple of those. One related to healthcare workers and where do they sit in the screening priority, and maybe why are they not higher in the screening priority?
Sure.
So would you like to address that, Cecily?
Sure, yeah. So they are addressed in the screening document. They're housed together with populations that have clinical risk factors for TB, and it's not perhaps exactly a clinical risk factor, but it's exposure in that environment, and they can be screened in the clinical setting. So they are listed as a population that can be prioritized, again, depending on the local context and local burden. We don't yet have evidence to have a strong recommendation specifically for them. So that's what is needed before a strong recommendation can be put in that way. But they're certainly included as a population to be considered for screening in the clinical setting.
Okay, thank you. And Avinash, you were responding to some of these, but I thought it'd be worth hearing you maybe summarize your thoughts on the issue that treating immunocompromised people on biologics. I mean, some of the questions that came up were, if you don't have rifapentine, what regimen would you use for prevention? How long would you treat people who were going to go on a biologic before you started the biologic? Those kind of things.
Yeah, I think we, Dennis and myself, we tried to respond, and in general, we encourage countries to go towards shorter regimens. So if rifapentine is not available, maybe the rifampicin isoniazid regimen 3 months is an option. But again, we'll have to look for other comorbidities. What are the other medicines the patient is receiving? Is there drug-drug interaction? So these sort of issues. But also for that specific question, as Dennis also mentioned, ideally we should give the TPT first and then go for that for management of the condition. But the idea is to move towards shorter regimens, and most of them are, and all of them are equivalent in terms of efficacy.
Okay, thank you. We had a question actually that came up earlier, and I don't think we got to that one. And Nina, this was your question about bidirectional screening for TB and COVID, I'm going to ask Dennis, maybe if you would be willing to respond to that.
Yeah, thanks very much, Chuck, and thanks, Nina, for bringing this up. So, well, we don't have the sort of evidence-based guidelines focused on questions like this, but I think we can apply a lot of the principles that we use for determining when to test TB patients, and also the new guidelines that are coming up about what would be a case or like a case for evaluation of COVID-19, and then combine the two together and come up with some useful implementation type guidelines. I think the Global Fund is in the process of issuing some guidelines in the coming days about this. We're working with them and other partners to bring this out better. But essentially, there will be in this small document like 3 case scenarios where you have someone who has symptoms which could fit into either case definition of TB or COVID-19, what to do in that situation and how to test. Then situations where you have a confirmed COVID patient, and then when to test for TB, and inversely, if you have a confirmed TB patient, when to test for COVID. So in principle, it's an application of the typical symptoms that you find in COVID and TB. They do not always overlap. Okay, there are instances, of course, where early on in the process of disease that you might have some overlap with cough or some chest X-ray findings, and then you would need to test for both simultaneously. And then you have situations where, for instance, you have a confirmed COVID case, and this patient is after improving, maybe still has symptoms, and you'd want to exclude other diseases, amongst which TB, particularly in high TB burden settings, and likewise a TB patient, right, in a COVID pandemic situation with community transmission. There you need to probably test quite a few of the patients. We've had instances where TB patients in a ward were simultaneously exposed and got infection. So in that situation, of course, you'll be tested. So there will be a few situations, and also highlighting the tests to use and the pros and cons of antigen testing, for instance, for SARS-CoV-2. So that will be highlighted in this document.
Thank you, Dennis. It seems to me this is a good place to end today. COVID and TB. I want to thank the speakers for incredible talks today, my co-chair, and also the participants. At one point, I saw almost 200 people online, which is incredible. And of course, I would like to thank the union for providing this forum for us to be able to share our thoughts and to see the incredible work that's being done at WHO. Matteo, I think I'll hand it back to you to close us out.
So thank you, Chuck. Just to add my thanks to all of those who have been able to stay with us for such a long time. 3 hours. We had more than 150 people staying with us for 3 hours with peaks of 220, 230. And thanks to the speakers, and also, of course, thanks to the union and Carrighini in particular, who have been able to put us together and create this environment which has allowed this important discussion. And we remain available. If you still have questions, please do write to us, and we'll definitely be able to get back to you. Thank you very much, and have a good rest of the day.
Thank you, everyone, for attending today's postgraduate course. So once this Zoom meeting closes, you will see a survey appear in your browser. We would appreciate if you would complete it and provide your feedback. You will also receive in the next few days an email with a link to view the recording of today's event. And we want to remind you that discussion like today's centered around the latest research in science take place every year at the Union World Conference on Lung Health. So join us for this year's virtual conference. on the 19th to the 22nd of October. On behalf of the union and our presenters, thank you for joining us today and enjoy the rest of your day. Thank you.
Hi, thanks.